Hello, my name is Damian Berg, and I'm with the Healthcare Sterile Processing Association, also known as HSPA. HSPA is an amazing organization that encircles the globe. We are the organization for sterile processing professionals that really focuses on certification, advocacy, and education. I am happy to present to you today a 2021 virtual conference favorite, presented by Ofsted Associates. This topic is relevant today because it is talking about COVID and how it impacts our everyday lives back in 2020, 2021, and now in 2022. This presentation will show that our sterile processing professionals reach beyond the red line. We are more than just sterile processing professionals. We are experts in what we do. And Corey Ofsted and her team do a great job in presenting that. So today, I welcome you to sit back, watch, and learn along with many others around the globe. Thank you.
Welcome, everyone. My name is Corey Ofsted, and Christina and I are happy to be here with you today to discuss infection control in the COVID-19 era and beyond. My team put this presentation together after hearing what topics were of most interest to you. So these are our disclosures, and you can see that we receive funding from a lot of different companies. The important thing is that our study sponsors are not involved in designing or conducting our studies, and the opinions that Christina and I are sharing today are our own. By the end of this presentation, we're hoping you'll be able to explain strategies for reducing the risk of infection associated with procedures, discuss the roles of screening and vaccines in protecting patients and healthcare personnel, and describe several reasons for maintaining universal precautions. You may know that I'm an epidemiologist, and my team designs and conducts real-world studies to find out how things are going on the front line and to help develop practical solutions. I'm joined today by my colleague, Christina Hopkins, and we'd like to tip our hats to our fabulous team, whose expertise and hard work allow us to be here today. Now, many of you know and love our colleague, John Island, who had planned to be here presenting with us today. And John said to tell you that he's been missing you. We were going to do a presentation together on endoscopes last spring at ISHM, but he was deployed to an Army base in Texas, where he returned to active duty as a nurse manager and oversaw a COVID-19 testing center. Fortunately, he survived that deployment and he was home in time for the holidays. Now, John had a post-deployment physical a few months later, and a routine x-ray revealed that he had a mass in his lung. Imaging later confirmed that there was an abnormality there, and they said he needed to have a biopsy, which was performed using bronchoscopy and an EBUS scope. Unfortunately, the diagnosis was lung cancer with involvement of his lymph nodes. Now, those of you who know John know he's fighting it with a great team and all he's got. He's made it through an aggressive course of chemotherapy and radiation. He's on a little break right now, and he's going to start immune therapy shortly. And he did ask me to share all that medical information with you because we think there's a couple lessons for you and everyone. First of all, this can happen to anybody at any time. Suddenly, you need to have a procedure with an endoscope. If you've heard our presentations before, you know that reprocessing endoscopes doesn't reliably work, and most scopes are actually damaged and dirty when they're used on patients. John's been saying the same thing to you for years. We've got to make sure that every scope is clean and safe for use for every patient, every time. Every time. And this really brought it home for us. I'd like to comment on just one thing related to this conference. You know, the folks at ISHM had to make a really tough decision about whether to go forward with a face-to-face conference or convert to a virtual format. Many of us were really looking forward to seeing our friends and getting a big dose of education and moral support from our friends at ISHM, which, by the way, is my team's favorite conference every year. However, I fully support ISHM's decision to take action based on evidence, to make an evidence-based decision, because it simply would not have been safe to gather hundreds of people from hundreds of different hospitals together in one location, especially a location that was undergoing a big surge in COVID cases when they had to make that decision. Now I'd like to turn things over to Christina, who's going to tell you what life has been like for your fellow ISHM members and answer your questions about COVID-19. After she's done, I'm going to talk about vaccines, superbugs, endoscopes, and infection control in general. And now, Christina.
Thanks, Corey. Christina here. This year's been a hard year for a lot of reasons, and COVID has been at the center of much of it. We know things have been tough and lonely on the front lines, so we wanted to share a little bit about how the last year and a half have been for all of you. To do that, we worked with ISHM this summer to send out a survey. We really wanted to know what the last year and a half was like for ISHM's members on the front lines, what you wanted to learn more about, and what kinds of support you need and want from ISHM. ISHM sent out that survey electronically in early August, and over 1,600 of you and your fellow ISHM members responded. So let's dive into what you guys said about your experience with COVID-19. We heard from friends we talked to in the field that a lot of people saw their role and their workload change, and judging by your responses, they weren't alone. 30% of you reported that your role changed as a result of the pandemic, and over half of you had different hours than you did in 2019. Given the cancellation of elective procedures and other financial challenges in healthcare settings, a third of you ended up working fewer hours, adding the stress of reduced wages to all the other stress of the pandemic. For a quarter of you, it meant more hours, which, combined with changes on the home front like distance learning, sick loved ones, and other new concerns, must have been really intense. But what really broke our hearts was that 40% of you reported feeling less safe at work. You guys are the heart of the hospital. You're the foundation of patient safety. And frankly, it really stinks that so many of you were put into especially tough situations this year. This survey didn't drill into what factors contributed here, but we wouldn't be surprised if lack of PPE might have had something to do with it. We heard a lot about shortages of face masks, face shields, and respirators from the news, but it looks like you guys were running out of everything. Almost 80% of you had shortages of at least one type of PPE, but when we broke it down, over half of you were missing more than one item. Guys, if you look up at the red chunk in the upper left corner, almost a quarter of you were missing 5 or more items, and there were only 7 things on the list. Ultimately, the data points aren't really the point here. The point is that you were missing a bunch of stuff. You weren't adequately protected, and that just isn't okay. Another thing we heard a lot about in the news, along with PPE shortages, was that many institutions had to reprocess single-use PPE like N95s. In fact, the FDA actually released an emergency use authorization to allow for reprocessing of N95s, and 45%, that's almost 800 of you, had to do that at your facility. What surprised us was that hundreds of people reported reprocessing face masks, face shields, gowns, gloves, and none of those were included in the FDA authorization. That really put you guys in a pickle, and we really hope that you aren't still dealing with the PPE shortages that led to that. We know that PPE is essential in decontam, and while 70 to 75% of you have received training in using, putting on, and taking off PPE, that's 25 to 30% of you that haven't received that kind of training. And the numbers are even worse for learning how to use new PPE products, which I bet a lot of you ended up doing over the last couple of years. New PPE should be just like when a new instrument or a new endoscope comes in. You've got to learn how to use it properly. If you want to learn more about how to use PPE and why it's important, we actually have 2 free webinars on PPE and respiratory protection that we'll link to towards the end of our presentation. We know it got really desperate out there, especially early on. We heard some crazy stories in the early days about hand sanitizers and boxes of procedure masks just sprouting legs and walking out of the hospital. What I want to point out to each and every one of you is that we know that the pandemic was really isolating, with surges, with canceled meetings, and not being able to connect with the people that really fill you up. But your own responses show that you guys were in this together, and that whatever you had to deal with, you weren't alone. So when you were running out of disinfectant wipes, that was almost half of you, or relying on local distilleries because 35% of you were running out of hand sanitizer, or when a quarter of you weren't able to get the reprocessing supplies you needed, which I bet put you in some tight spots, you weren't the only ones. And what I think is really cool, and I just want to take a second to acknowledge, is that despite 2020 and 2021 being really hard, You guys are still rising to the occasion and you're still looking out for each other. When we asked what kind of support you needed, you responded overwhelmingly with things like, where can I find free accessible online education? Good news, we've got you covered on this, and we'll circle back to that at the end of our presentation. How do we continue to network, to mentor, and to connect with others in our field? How do we keep supporting young people who might be interested in a career in sterile processing? You guys are hungry for resources to help you keep each other safe, how to manage supply chains and logistics, how to develop relationships with OR, nurses, and other stakeholders. Our friend John was always a firm believer in sharing coffee breaks with and getting to know all of the people on your team. And most importantly, you want to know how to advocate for yourselves and for your colleagues as professionals and as key members of the healthcare team. We'll circle back to this too at the end and make sure that you guys leave this talk with a few resources and educational materials that you can learn from and that you can bring back to your departments. With that, let's switch gears a little bit and get into what you guys really want to know about, which included vaccines, COVID-19 variants, followed by superbugs and outbreaks, endoscope processing, and a smattering of other infection control topics. Now, Corey and I are going to hit on all of these, but let's start with COVID-19. Now, just a little aside here. The last 2 years of COVID-19 have been a crazy roller coaster, and we're going to get to that. However, we just wanted to point out that the data we're going to be diving into reflect what we know on the day we recorded this. However, science is constantly evolving. That's the beauty of it. As we learn more, some of today's information might go a little bit out of date, but our ability to update information and draw new and better conclusions is one of the most powerful parts of science, and sometimes you've just got to grin and bear it. So what did you guys want to know about COVID-19? We received a lot of questions about safety. Is it safe to go to meetings with unvaccinated people? Is it safe to take our masks off? You wanted to know about COVID-19 variants and what COVID means for you in the SPD, and how to think about COVID compared to other infections like flu. And finally, what does the future look like? And how do we keep this from happening again? I don't have answers for those last few questions, but let's start with the question we've heard a lot since the very, very beginning. How bad is this whole COVID thing? Let's put it into perspective. When we're talking about catchable disease, it all starts with a single infection, that one person who gets sick. From there, we have outbreaks, which are multiple people in a group who are doing the same thing or who are in the same place who got infected. Say, people who all ate from a contaminated salad bar, or people who recently had an ERCP procedure. Even bigger than that is an epidemic, which is when many people catch a disease in a particular region during a particular time. This is similar to an outbreak, but generally larger. So instead of talking about a single institution, maybe we're talking about infections occurring throughout the whole US. And finally, we have a pandemic, which is basically a really big international epidemic where people all over the globe are getting sick. And that's where we're at now. There might also be one other demic that you've heard of before, which is endemic. Endemic is when something becomes a constant or normal in a certain region, like colds or RSV that circulate every winter. So let's put COVID-19 into some historical context by comparing it with the last major pandemic, which was the 1918 influenza pandemic. In that pandemic, 500 million people were infected, which was a third of the global population at that time. There were 50 million deaths globally and 675,000 deaths in the US. And just a side note, we actually surpassed the US 1918 influenza death count just a few weeks ago with COVID-19. When influenza emerged a century ago, we had no vaccine, we had no antivirals, and we had no antibiotics for secondary infections. In fact, antibiotics weren't even going to be invented for another 20 years. According to the CDC, the only things we could do to try and control the spread were, quote, isolation, quarantine, good personal hygiene, use of disinfectants, and the limitations of public gatherings, which, and tell me if this sounds familiar, quote, were applied unevenly. Now let's fast forward a bit to where the situation with influenza stands now that we've had 100 years to figure out how to prevent and treat it. Well, there are still about 1 billion cases globally every year. We do have annual vaccines, but they're only about 40 to 60% effective because new strains keep popping up. We do have antivirals, but they're expensive, generally recommended only for high risk or really sick patients. And studies show that they may reduce illness severity and duration, but there is a laundry list of side effects, including respiratory, gastrointestinal, and neurological issues. In other words, even after 100 years, we still really haven't figured it out. So what am I getting at here? What I'm getting at is why it felt like COVID-19 has been such a white-knuckled roller coaster ride. Science is hard. We've had a century to get only marginally good at flu, and we haven't even had 2 years to get our arms around COVID-19. Let's expand that red dot at the end and take a look at what the last couple of years have looked like. So COVID-19 emerged sometime in late 2019 in China, and the first infections, or the first outbreak, involved a bunch of people who developed pneumonia after visiting wet markets in Wuhan. It developed into an epidemic as it spread throughout China, and then in January 2020, we recorded the first case here in the US. In March 2020, COVID-19 was spreading in multiple countries throughout the world, and it was officially declared a pandemic by WHO. The pandemic hit 1 million cases in April, though that is likely an underestimate due to lack of testing, lack of recognition. And the pandemic continued to escalate from there through 2020, all the way until December, when, in the middle of a raging surge that I'm sure you all remember, a couple of very important things happened. First, the US approved 2 vaccines for emergency use, Pfizer and Moderna, and began administering them to healthcare workers and the elderly. Second, we started seeing the first COVID-19 variants of concern. Alpha emerged in the UK and Beta emerged in South Africa. We did hit a good stretch there in early summer of 2021 with growing vaccine coverage in the US and other high-income countries. But then Delta emerged in India and quickly established itself as the dominant strain throughout the world. And since then, things have taken a little bit of a nosedive. Delta's been a real game changer, and the conversation has shifted back to containment strategies like ongoing vaccine campaigns, booster doses, masking, and social distancing. In other words, it's looking like we still have a ways to go. Currently, there have been over 230 million cases and almost 4.8 million deaths globally, and 44 million cases and over 700,000 deaths in the US. Despite almost 2/3 of people in the US and 45% of people globally having received at least 1 dose of vaccine, we're still experiencing yet another major wave of infection. So what's going on with that? In a word, variants. Before we get into details, let's talk a little bit about where these variants are coming from. When viruses replicate themselves in our cells during an infection, they have to make a lot of copies of themselves. So let's pull up a little copy of our virus guy over here on the right. Now, the machinery that viruses use to copy themselves, it's not all that good at it. Sometimes it makes mistakes, and you might hear these called mutations. Sometimes those mistakes can cause little changes. So if we look over here on the right, maybe our copy swaps his yellow ball cap for a yellow beanie. A small change, and he still looks pretty close to the original. On the other hand, sometimes mistakes or mutations can cause really big changes. So in the case of our copy, maybe he ends up with a purple shirt instead of a green shirt. He still has a lot of the characteristics of the original, but he's starting to become a little harder to recognize. Finally, sometimes multiple mistakes can occur, or they can stack up over time, and suddenly our copy over here is sporting teal slacks, green shoes, and perhaps a very stylish mustache. As our copy becomes more and more different from the original, even if we've already been infected or vaccinated, it gets harder and harder for our immune system to recognize it. If you've been trained to spot the guy on the left, do you think you'd pay attention to the guy on the right? When we apply this to COVID-19 variants, most of them have a combination of different mistakes going on, many of them involving the spike protein. Oops. The spike protein, of which I've highlighted a few over here on the right with the orange triangles, is important because it's how the COVID-19 virus binds to our cells, and it's also a major target for our immune response. Mutations or mistakes the virus makes when copying itself could change the shape of the protein, like changing our orange triangles to sneaky gray circles. This could do a number of things, like make it better at binding to our cells, which would make it more contagious, or make it less recognizable to the immune system, which might mean that vaccines aren't as effective. Corey will get into this in a little bit in a few more slides. But before that, let's talk about what we mean by more contagious. How contagious or transmissible something is refers to how easily it spreads between people. The more contagious the disease is, the more people will likely get infected. Now, you might have heard people on the news talk about something called R0 values. What it means is that in a population where no one has any immunity and one person got infected, how many people is that one person likely to infect? Let's start with flu, and just to note that I'm simplifying some of the numbers here. So let's assume someone with flu is likely to infect about one other person. So one person infects one person. So by round 2, you have 2 infections. That person from round 2 infects one person in round 3, and so on and so forth. After 10 rounds, we have about 10 infections. But what if one person could infect 2 people, meaning that the disease has an R0 of 2? If we play this out, one person infects 2 people, who go on to each infect 2 more people for a total of 4 new infections. And those 4 new infections go on to infect 8 more people, and so on and so forth. And it starts to stack up quick. If we plot it out on a graph, we can see something called exponential growth, which is a fancy way of saying we're going to end up with a lot of infections from one sick person. So it turns out that the original COVID-19 strain has an R0 of a little more than 2. We'll simplify the numbers again, but if we play that out for a few more rounds of infections, you can see that the infections grow a lot faster than the flu, and that after 10 rounds, we're at over 1,000 infections. And this is why Delta variant is such a big bummer and why it's causing so many problems right now. Remember how we talked about how some of the mutations can make the virus more contagious? Well, there are some new estimates out there about Delta that put its R0 value between 5 and 8. Let's take the lower end of that range and see how an R0 of 5 compares to flu and to the original COVID-19 virus. Yikes, guys, Delta is a lot more contagious, and that's why we're seeing areas with low vaccine coverage spiking with new infections. One reminder as we take in these numbers is that COVID and the Delta variant COVID and the Delta variant, as well as flu, are all contagious. But we're lucky to have a lot of people with immunity from the vaccine, and there's also immunity from catching COVID. So we aren't in the same place as we were in 2020 when this emerged. And this is why interventions like vaccines, masking, and social distancing are so important. If we go back to that initial person pyramid, we see that big upward slope on the right. But what if that person on the right in the second row is vaccinated? So when they meet our infected person at the top, they don't get infected, and therefore they don't infect anybody else below them. That makes a huge difference. Maybe this person over here got sick, but some of their contacts were vaccinated, so they only infected 1 person instead of 2. And finally, maybe this person got sick, stayed home from work in the grocery store, and wore a mask at home to protect their family members. They protected everyone they might have exposed. All of these measures individually can have an effect, but together they can have a large impact on how fast infections stack up. Unfortunately, we didn't stop COVID-19 in its tracks with masking, vaccines, and social distancing. And that means we're likely going to have to continue dealing with the variants that are out there, as well as new ones. We won't spend a ton of time on this slide, but I just want to point out that there have been a number of major variants so far, and there's been 4 main variants of concern, including Delta. The new variants seem to be more likely to be contagious, so they often spread quickly once they get into a new population. Luckily, the variants largely haven't become radically worse. There is some evidence suggesting that Alpha and Delta may cause more severe disease and hospitalizations, but so far, the vaccines continue to work, especially against severe outcomes like hospitalization and death. However, if more variants emerge, they could change in a way that makes the vaccine less effective. And that's why it's so important to get as many people vaccinated as we can. With that, I'm going to turn it back to Corey for a section on vaccines.
Thanks, Christina. Now we're going to talk about vaccines. In our survey, we asked what you wanted to know about vaccines, and we received hundreds of responses, including how safe are they really, and what's in them? How is a COVID vaccine made so quickly? Why do we need them when people are still dying of COVID, even though there were vaccines? Will there be a COVID booster shot? And what's the best way to encourage other people to get vaccinated? So we'll jump into that, but first, you might be wondering, what's an endoscope expert doing talking about vaccines? That's actually a great question, and I'll give you a little bit of history here. A long time ago, I worked as a hospital lab tech while I was taking classes for college. And then I worked in the vaccine research lab at Mayo Clinic while I was working on my master's program. And I've been doing vaccination studies ever since. So you might have noticed on some of my slides previously, we have cartoons that feature GI bugs and endoscopes. And the artist who designed that cartoon is actually a sheet metal worker at a big factory that participated in a flu shot study we did a few years ago. We loved his artwork so much that we asked him to design our educational materials for some of our other vaccination studies. And here's what he came up with. Aren't they fabulous? The cartoon in the middle with the flu bug wearing scrubs cracks me up every time I see it. On a more serious note, we loved working with this artist because he really understood how to communicate with folks who work on the front lines. We've made some of the materials that he designed and some of our other flu materials available for free on our educational portal if you're interested in that. So let's jump in. What's the point of vaccines? Now, the first thing is that vaccines are basically a training program for your immune system. They contain tiny fragments of nasty germs or something that will allow your body to recognize a germ. It's enough to wake up your immune system, but not enough to actually give you an infection. With vaccines, our body can get exposed to the germs and build up immunity without actually having to go through the infection and take all the risks associated of having bad outcomes. Now, some people are afraid of having a sore arm or feeling really funky for a couple of days after they get a shot, and that's normal. Actually, those side effects are real, and I don't like them either. But I think of them like aches and pains that we experience when we have a rough day at the gym or on the field. And you know, if you or your kids are going to be great at anything, you got to practice, practice, practice. And vaccinations simply give your immune system a chance to practice before it's faced with a fierce opponent. But this isn't a game. The vaccine is intended to prevent really serious illnesses that could make you sick or kill you. So a bunch of people wanted to know how vaccines are developed, and I'll take a crack at that now. So vaccine development generally starts in a lab, and a good vaccine candidate is tested in animals to make sure it's safe and effective at getting an immune response in those creatures. If that goes well, they do a phase 1 safety trial, where a few brave, healthy volunteers receive an experimental vaccine to see if it causes any severe side effects or really bad problems. If nothing really bad happens, the process moves on to phase 2, where researchers try to figure out how big of a dose they can give people without giving them bad side effects. Now, if that goes well, we move on to a phase 3 efficacy trial. Now, that's the first time we're trying to see if the vaccine works. Before then, we're just trying to see if it's safe. In phase 3, we attempt to learn whether it works by giving it to thousands of people. And we compare how they do, whether or not they get an infection, to people who either didn't get a shot at all or got a shot with a placebo or not a real vaccine in it. Now, we can't intentionally expose people to infection, so we just have to wait around and see how it goes, whether they get exposed during their normal daily activities. And this whole process can take 10 years or more. And if that happens to go well and we come out of it with a good vaccine, then the manufacturer can start making vaccine, packing it, doing the quality assurance, training people on how to give it, et cetera. And all that has to be done before we can deliver vaccines, which takes a few more months. Now, we got a lot of questions about how we were able to do COVID vaccines so rapidly. And there are a few things going on that contributed to that. One is some of these companies had already developed a foundation for rapid development of vaccines, but the government gave them a whole lot of money to prioritize doing this for COVID. And people were eager to be involved, so they had no trouble recruiting people for the trials. In addition, the FDA and other agencies fast-tracked their process, and the manufacturers were allowed to begin manufacturing the vaccine before they actually finished the clinical studies. And that allowed them, the minute FDA approved it, to ship and begin giving the vaccines. So it was a fast process for those reasons. Now, before there were vaccines for COVID, as you know, it was running rampant through communities, causing a lot of severe illness, killing a lot of people. The government at that time set an initial target of 50% vaccine effectiveness. And they said, basically, any company that could come up with a vaccine that was 50% effective, that'd be good enough. Now, some of the companies thought they could come up with a vaccine that was 70% effective, but nobody expected what happened with the Moderna and Pfizer vaccines. They were way more effective than anyone hoped, 95%. However, to get to that level of protection, we had to give people 2 shots. And you may recall that that vaccine has to be kept really cold, frozen until just before use, or it loses its effectiveness. So along comes the J&J vaccine, which was built a little bit differently and didn't have to be kept so cold. And it was going to hit its effectiveness with just 1 dose. When the data came out, everyone celebrated because they hit 67% effectiveness. So that's way higher than the 50% target. And it would have all worked out great if we'd had enough vaccine to immunize everybody in the world last spring, but we didn't. And vaccines were available only in wealthy countries and those who had a very strong science infrastructure. Since we didn't vaccinate everybody right away, what happened? The variants that Christina told you about. So how does the vaccine do when we're faced with variants? Well, one study compared vaccine effectiveness for the original virus and for the Delta variant. With the original vaccine, the vaccine in the original virus, they found that it was 91% effective. Then when we looked at the Delta, which was kind of sneaky with the changes that it was 66% effective. So it did have a drop in how effective it was, but it's still way above that 50% target that was initially set. So we do consider the vaccine to still be highly effective, even with the Delta variant. So that leads us to the question of breakthrough infections. And we got a lot of questions about this. Why do they happen? Well, the first thing is no vaccine is 100% effective. And immunity for most vaccines wanes over time. That means it kind of reduces slowly over time. And the variants absolutely impact vaccine effectiveness. That's why we need to get a flu shot every year, because the flu virus mutates almost every year. And our bodies have to get exposed to something that's pretty close to the original virus in order to wage an effective immune response against it. Now, booster shots are kind of like annual training and competency testing for our immune system. And we've come to expect boosters for things like measles, tetanus, whooping cough, and flu. It's looking like COVID might be similar. Now, we got some questions about the best way to convince other people to get shots. And I got to tell you, I don't think you should try to convince anybody with data. Piling on the numbers really doesn't work to change people's minds. And you have to, even if you have a lot of compelling evidence. Instead, here's what you might try. Explain how vaccines work. And I basically say it's a training program for the immune system. It gives your body a heads up so it's ready to fight when it encounters the germs. You could also try telling them why you personally got vaccinated, like maybe to protect yourself, protect other people that you care about, ensure your safety at work, or reduce the risk of bad outcomes, which could be medical or social or financial. And now that there are these vaccine mandates for healthcare workers, it could take a big hit to your pocketbook if you decline and you're a healthcare worker. So if those explanations don't work, you could try telling them a true story about what's happened at work or in your circle, and just simply say you don't want that bad thing to happen to them or their families. Now we're going to turn our attention to infection control during COVID-19 and answer some of your questions about that. So our survey asked, what do you want to know about other infections? And we heard from the field, Are we making any progress in reprocessing endoscopes? What do we expect beyond the pandemic? And how are other bugs doing? What are some of the more common germs that we're processing? And it's funny how MRSA and other healthcare associated infections have taken a backseat to COVID, and our superbugs more difficult to kill. So let's take a look at some of those and show you evidence. So with regard to healthcare associated infections, I wish I had good news for you, but this section is pretty sobering. While we were busy and distracted by COVID, infection control has taken a huge hit. This chart shows the results of 2 recent studies that looked at the incidence of infections that patients pick up in healthcare settings. Now, the list on the right shows what they looked at. So they looked at CAUTI, which is catheter-associated urinary tract infection, MRSA, which is a superbug, ventilator-associated infections, and CLABSIs, which are central line-associated bloodstream infections, very serious infections. Now, the first study found that there were huge increases in all of these infections in 2020. And the second study found the same thing. Now, this is really disappointing because hospitals and other healthcare institutions have been making big progress toward eliminating these preventable infections. And one of these research teams noticed that infection rates went up significantly wherever there was COVID-19 surges. So I think we just got distracted and our priorities shifted. So now is the moment you've all been waiting for, and I'm happy about it. I get to talk about endoscopes for a moment. So let's look at endoscopes. There have been a few developments you should know about, and one of them is in the spring, the FDA sent out a safety communication saying that they were investigating reports of infections associated with urology scopes. Now, this warning said that they'd received 450 reports on urology scopes just in the last 4 years. And they showed device contamination and also patient infections. Unfortunately, with 3 deaths that were attributed to the use of dirty urology scopes. The FDA warning recommended that people follow the manufacturer instructions, don't use scopes that fail the leak test, perform routine inspection and maintenance, and inform patients of risks associated with ureteroscopes. Now, I wonder what would happen if we actually told patients that they were going to have a procedure with a dirty ureteroscope. Okay, well, anyway, this summer, the FDA released another safety notice, and this one was about bronchoscopes. This warning said that there had been 867 new reports and 7 patient deaths associated with dirty bronchoscopes. The notice had several recommendations too, including that we should consider shifting from HLD to sterilization. And I agree with that, absolutely. They also urged users to follow manufacturer IFU, perform your routine inspection and maintenance, and not use damaged devices. In addition, again, they said discuss the risk of infection with your patients. And they ended up saying that you should consider shifting to single-use bronchoscopes in what they called high-risk situations. So let me ask you a question. When is getting a bronchoscope shoved down into your lung not a high-risk situation? I don't think it's ever okay to use anything other than a sterile scope if you're going into my lung. And as John Island says, clean scope for every patient, every time. So we appreciated the FDA safety notice, and we share their concern about urology scopes and bronchoscopes. Let me tell you why. During a study we did on flexible ureteroscopes, we did tests on scopes that had been cleaned and sterilized using hydrogen peroxide gas. As you can see here, a lot of scopes still had soil on them, and 100% had visible defects. Surprisingly, we found live bacteria in 2 scopes, which should never happen if sterilization worked. This reinforces the concept that you have to get it clean for sterilization to be successful. Now, when I say 100% of the scopes had visible defects, what am I talking about? Well, this wasn't subtle. This is a patient-ready ureteroscope that's still in the tray after sterilization. We just popped the lid. What do you see? Well, the first thing I saw was white foamy blobs of residue near the instrument port. We don't know if that's Dried out or processing chemicals, or possibly residue from adhesive that's breaking down, as one expert guessed. What else do you see here? Well, there's a bunch of white debris that looks like lint or threads. It shouldn't be there anyway. And how about the yellow discoloration on the rim of the biopsy port? It was gunky and sticky. I can't really even imagine what that could be. So my team has also done studies on bronchoscopes in 5 hospitals, and we found that 65.7% of patient-ready bronchoscopes had microbial growth. Now, okay, just sit with that for a minute. 2/3 of bronchoscopes still had germs on them after they'd been reprocessed with HLD. And 28.6% had high concern organisms. Now, those are nasty germs that can cause severe infections or death. Now, the species included several waterborne pathogens, E. coli, which is a GI bug, and mold. In the picture on the right, that's the 3 white domes that are amid all those orange dots, which are Sphingomonas, or a waterborne bug. This suggests that the scopes weren't being dried after reprocessing. But during the audits, our team discovered that there were also major reprocessing breaches, so people just simply weren't doing the steps. Now, in the bronchoscope studies, we also found visible defects or debris on 100% of scopes. Let me show you an example of that. This is an EBIS bronchoscope, which has a delicate ultrasound probe on the end. That's the pink thing. So can you see any issues here with this one? We saw a blob of black stuff under the edge where the balloon is attached. Now, in keeping with our usual practices, when we see residue or foreign substances on scopes, John generally pokes it with a sterile swab like this, and I take photos. So when he poked it with a swab, what do you think happened to the blob? It moved. So how do you feel about that? You know, the scope has residue that was easily dislodged by poking it with a sterile swab. In my mind, that means it could come off in a patient's lung. And that makes me really grumpy, as no patient deserves to be exposed to other people's soil or debris. But I got to tell you, this is hitting me really close to home now that John has to have bronchoscopy procedures as part of his cancer treatment. And we just don't have any confidence that it'll be clean or safe for use. I think it's really time to do something to address this. Now, sometimes when we share data like this with doctors and nurses, they say, it doesn't really matter because we're going in through a dirty orifice, the mouth or the nose or the other end. But there's plenty of evidence showing that there are outbreaks associated with all types of endoscopes, with ureteroscopes, cystoscopes, bronchoscopes, colonoscopes, and ERCP scopes. A lot of these outbreaks involve germs that are called multi-drug resistant organisms, or CRE, or superbugs. And I want to unpack that a little bit. When I talk about superbug, I'm not just talking about a scary bug. This is a technical term that refers to bacteria that have figured out how to evade antibiotics. They're commonly known by abbreviations that refer to the germs and the drugs that they know how to evade, like MRSA, which is methicillin-resistant Staphylococcus aureus, or a staph germ that has figured out how to evade an antibiotic called methicillin. There's VRE or CRE. Now that's a super duper scary superbug because carbapenems are some of the strongest weapons we have. And when a germ figures out how to evade this antibiotic, nothing can kill it. So when a person gets exposed to a superbug, it can cause severe illness that doesn't respond to normal antibiotics, or it can live inside them, which we call colonizing them, without causing problems for a while. But it can train other germs to evade antibiotics. Now, treatments for eradicating a superbug can be life-threatening. They frequently harm the patient's kidneys or liver or their heart. And often the superbug wins and the patient dies. In my view, we need to prevent the development and transmission of superbugs by cleaning and sterilizing instruments, cleaning the rooms, washing our hands, etc., not hoping that antibiotics are going to take care of infections when they happen. Now, for your work, it's important to understand the difference between superbugs, which resist treatment with antibiotics, and germs that are resistant to chemicals that we use for cleaning and disinfecting surfaces or instruments. So this chart shows how hard it is to kill various types of bacteria, fungi, and viruses. The germs that are the hardest to kill are bacteria that form spores, which are tough shells that protect them, and mycobacteria that cause problems like tuberculosis. There are certain viruses that we say don't have an envelope around them that can cause diseases like polio or norovirus. And then there are fungi. Next are fungi and fungal spores, which can cause pretty pesky illness. But the bacteria that are below that are gram-negative bacteria. So the ones that we worry about, we call superbug. Those are generally gram-negative bacteria. And they're actually pretty easy to kill with our normal disinfection and cleaning materials. And then we have germs called gram-positive bacteria, which are thought of as not so serious, but the infection called MRSA is a Staph aureus thing. So these are actually easy to kill with normal cleaning and disinfectants, but really hard to kill once they're infesting a patient. And then we try to kill them with antibiotics. So the easiest to kill group is called enveloped viruses. This group includes COVID-19 and measles and influenza, HIV, and hepatitis. Now that's because these viruses are surrounded by a little layer or an envelope that contains lipids or fats. So what happens when you heat up fats? They melt. And what happens when we add detergent to hot water? Fats and oils just simply wash away. So when we use hot water and detergent, we can destroy the outside of these envelopes around these viruses, which disables them. And disinfectants can disable them by destroying the lipid layer too. So we can get rid of COVID germs and flu germs, et cetera, by doing what we already know how to do. Manual cleaning with detergent and hot water, and using disinfectants to clean our work area and instruments that can't be sterilized. All right, time for something completely different. In 2021, progress was made on several guidelines related to reprocessing, and you should know about these. First of all, the Multisociety group published a new guideline on reprocessing for GI endoscopes, and that's a game changer. AAMI is publishing a guideline called ST91, Standard 91, on flexible and semi-rigid endoscopes, and we're anticipating that that may come out by the end of the year. And the same group is working on a technical report on dilators and ultrasound probes, which we're expecting sometime in 2022. So keep your eye out for that. Now, the Multisociety guideline, which already has been released, is a game changer. And I want to just unpack a few things in that. So first of all, it says that every person working in reprocessing should receive model-specific training and competency testing, and they should comply with infection control recommendations and wear gloves whenever they're handling endoscopes. Now, I want to talk a little bit about this concept that everyone should receive model-specific training and competency testing. This table shows you the number of steps involved in reprocessing various kinds of scopes. It's on the competency checklist for a manufacturer. And you can see there's no consistency whatsoever in how many steps the tech is supposed to be able to do for all these different scopes. For example, with bronchoscopes, there's 67 steps, whereas for an eboscope, another kind of bronch, but with an ultrasound probe on the end, there's 138 steps. And then reprocessing GI scopes has between 113 steps and 122 steps. And there's a huge variety in the number of steps involved in manual cleaning for various kinds of scopes. So keep in mind that the new guideline says every tech should get trained and then competency tested on all this stuff for all these different kinds of scopes. Now, the new Multisociety guideline also says that there should be dedicated space for reprocessing with separation of dirty and clean areas, which means no more reprocessing in patient care rooms. It also says HLD should be done in an AER. But here's the doozies. It says that manual cleaning must be initiated within 60 minutes of the procedure, or you have to follow the manufacturer's instructions for delayed reprocessing, which generally involves extended soaking and extra scrubbing. It also says you should use model-specific brushes for lumens, so no more using one type of brush for all the scopes. And it says you should be doing visual inspection with lighted magnification for every scope every time. Now that's a big change, and a lot of people don't know how to do that. So we have a webinar on visual inspection that could give you some tips for doing that, and Christina will give you the link at the end. Lastly, it says you have to completely dry endoscopes with at least 10 minutes of pressure-regulated forced air or a drying cabinet. In my view, these new guidelines are a giant step forward for processing quality. If those of you working in the field actually do them for every scope, every time. Okay, that was a lot. Let me take a breath here, and we're going to talk about universal precautions and infection control strategies. So I think some people are wondering, why do we always have to be top of our game? And the concept of universal precautions came about because we have to assume every person may be carrying an infection, and every instrument or device or surface may be contaminated. We can't know when we're going to be exposed. And so it could happen at the sink, in a procedure room, or in the restroom. And I want to note with COVID that certain types of screening, like asking if people have traveled recently or taking their temperature, may not identify people who are walking around carrying it, because a lot of people are asymptomatic or mildly symptomatic. Therefore, we have to take precautions to protect yourself and your patients all day, every day. Now, I'd like to say just a few things about respiratory protection. When we cover our mouth and our nose with filtering materials like a mask or respirator, it serves two purposes. First is personal protection, which keeps us from inhaling harmful pathogens and particulates. And then there's what we call source control, that prevents exposing other people to infectious microbes that may be expelled when we're breathing. Now, if you're skeptical that regular old masks are effective at stopping droplets from spewing everywhere, I urge you to take a look at our free webinar on respiratory protection. We have a bunch of photos in there that show what comes out of your nose and mouth and gets trapped by a mask during normal breathing and talking, not even with coughing or sneezing. And there's a link at the end of this presentation if you're interested in seeing that. Now, my worry about you guys getting droplets on you is big. And I was particularly worried when we heard that SPDs and endo units were rationing disinfectant wipes and running out of PPE. We're concerned because techs and decontam often get splashed with contaminated water, but there's no published evidence that there's exposure. So we worked with our friend Marie Brewer, who manages an SPD in Iowa, to document splashes happening in decontam. So you see those blue sheets of paper stuck to the walls and backsplash areas? When that blue paper gets splashed with water, it turns bright white. So Marie and her team attached it to surfaces and then to her PPE from head to toe. And then she went through the steps of reprocessing various types of instruments, though she used only sterilized instruments and clean sinks for these tests. And we took photos and videos to document what happened. Right away, we could see that manual cleaning and rinsing instruments generated lots of droplets everywhere that the blue paper turned white. And sinks, backsplashes, and counters got soaked, with droplets going at least 5 feet away. What happened to her PPE? Well, she got drenched from head to toe within just seconds of using a power sprayer. And we also found that pretty much everything she did at the sink generated droplets that got on her and all around on the walls and the floor. You can see the evidence for yourself if you watch our free webinar on splashes. And now I'm going to stop and turn it over to Christina to talk about what you can do to protect yourself and your patients.
Thanks, Corey. Let's wrap up with a few strategies and resources that you can use to protect yourself. First and most importantly, the best offense is a good defense. It's important to do whatever you can to minimize your exposure to COVID-19 or any other infections that you might come across. That includes social distancing when necessary, performing hand hygiene, and wearing PPE consistently and correctly. And finally, making sure your environment, whether it's a patient room, your decontamination station, or the kitchen sink, is clean and ready to go. And for those moments where you can't prevent exposure, make sure to give your immune system a fighting chance. That includes getting outside, eating well, exercising, and getting enough sleep. All of these boost your immune system and contribute dramatically to your overall well-being. And get your vaccines. These include the COVID-19 vaccine, but remember that COVID isn't the only bug that you face. Make sure you're up to date on your Hep B, MMR, Tdap, and of course your yearly flu shots. As for resources, what kinds of things were you interested in? A quarter of you responded with topics and areas that you were interested in having more resources for. A big theme was accessibility. How can you get access to free training and resources, whether in person or online? You were also looking for news and information pertinent to your jobs, things like technical information, industry news, and guideline updates. And finally, you're looking for more information about COVID-19. Luckily, I have good news for you as ISHM members. ISHM has a plethora of educational materials available on their website. These resources include things like webinars, podcasts, and other content that's available in whatever medium is easiest for you. In-person and virtual events on the national and local levels. Obviously, you're here, but also check out local and regional chapters that you can get involved with, and that might be easier for getting more of your department engaged. The Process magazine and digital newsletters, these are gold mines for new information and updates. And finally, they have a lot of endoscope processing specific textbooks and a certification process, things to help support you in your everyday job. And here at Ofsted, we spent the last few years building up a bank of webinars with a focus on quality management in endoscope processing and ultrasound probes, PPE, accessing, interpreting, and submitting FDA medical device reports, and occupational health in the SPD. All of these are available for free on our website, along with numerous other resources that Ofsted has made freely available. These include posters like the flu cartoons that Corey showed earlier, or PPE visual aids, a reprocessing time tracking worksheet, and links to other valuable sources of information. So let's recap. COVID-19 is a serious and highly contagious virus that isn't going away anytime soon. And although it's a big deal, it isn't the only scary bug you face every day. As a result, universal precautions and infection control basics are important all of the time, not just during a pandemic. And remember that you already know how to get rid of superbugs and scary viruses like COVID-19. Keep instruments and workstations clean, follow IFU for HLD and sterilization, always use PPE and always be careful taking it off, and do hand hygiene every time your gloves come off and frequently throughout the day. And when they're available, it's important to use vaccines to train your immune system to fight COVID, flu, and other infections in case you do get exposed. There are all kinds of easily accessible informational and educational resources available through ISHM, through us here at Ofsted, and through other agencies and organizations. Thanks for listening today and for participating in the chat. If you have any other questions for us, you can send those to info@ofstedinsights.com. And if you're interested in further reading, we've included a list of the sources we used in putting this deck together here, here, and here. Thanks again for joining us. We invite you to rate this session by taking a brief survey after this presentation and then submitting the presentation code to get your education credit.
Thank you for watching the presentation today. I hope you really enjoyed it. As sterile processing professionals around the globe, we are excited for what the future holds for us. I hope if you're not a sterile processing professional, you will come and check us out on our website, www.myhspa.org. We are here for the patients. We are here for the profession, and we are here most importantly for each other. So thank you very much for all you do. I hope you enjoy it, and thank Corey Ofsted Associates for a wonderful presentation. Thank you very much.